Hi everyone, my name is Arthur CURTARELLI. I'm from São Paulo, but I'm in New York doing an international fellowship. So this presentation will be online, and in the next few minutes, we will discuss about intravascular ultrasound, Ivus, to improve the quality of endovascular revascularization. So I have no disclosure on this presentation. Let's start speaking about the importance of Ivus. All vascular surgeons know the importance of Ivus in venous treatment, to use of Ivus in the diagnosis, to define compression, and decide the size and length of the device is undeniable. But some surgeons are still resistant to use the Ivus in the arterial territory, especially in the treatment of PAD. But angiography has numerous limitations as identifying of the plaque morphology and geometry. Even when we applying a biplanar angiography, the actual dimension, depth, and anatomic characteristics of the plaque elude these imaging techniques. So take a look in these two images. In the left image, you can see the angiographic and Ivus technical success after angioplasty, and in the right image, the importance of Ivus to define the size of the device and to have control after the procedure. The pancake effect, it's very famous. All knows about the pancake effect on the vein territory. And this occurs because the vein wall doesn't have a muscle structure. This not happen in arterial, but the mistake to over or undersizing the stenosis percentages can occur depending on how the surgeons take shot on angiography. So take a look on this image in the right side. Note the image and how stenosis can be interpreted in different percentages for the surgeon, depend how he do that. This is a very common mistake. So strategies evaluations of the arterial target to ensure the true lumen position, assess plaque morphology, and obtain the precise vessel diameter using Ivus has been extrapolated from the results seen in the coronary circulation, and it is very promising data regarding these benefits in setting of PAD. So because of that, recently, 4 pillars of Ivus in PAD have been presented. So take a look on these 4 pillars. The first one is visualizing the plaque geometry. The second is defining plaque morphology. The third, vessel sizing. And the fourth, guide wire orientation. Let's talk about each one. The very first one, pillar in Ivus in PAD, is visualizing the plaque geometry. So this is very important to correctly weigh, can change your decision in how to treat the patient. We know that Ivus is superior to angiography in different between echocentric and eccentric plaque. These images show that. Identifications of circumferential concentric plaque implies the need for pre-treatment of the vessel with a plaque modifications device to achieve optimal result. In some case, you can switch your decision to do an atherectomy. So look this concentric plaque on image A and the burden on imaging B, that is higher on one side of the vessel and often includes an area with a healthy wall vessel, just here. And this can help you to decide to use or not to use an atherectomy device and which one to choose. So the second pillar of Ivus in PAD is plaque morphology, the presence of dissection or chronic total occlusion, as we know, CTO. The use of Ivus permit the examiner to distinguish between 4 subtypes of atherosclerotic plaque clearly. Atherosclerotic plaque can be divided in these 4 types. So take a look. The first one is fat, the second fibrofat, the third fibrous, and the 40 calcified plaques. The knowledge of this plaque's quality helps the examiner adequately select the plaque modifications tools and the device. Plaque modifications permit a less aggressive PDA, thereby reducing the risk of barotrauma, dissections of the vessel, with subsequently need of utilizations of a vascular scaffold. So in some cases, you don't need to use a stent. So take a look on the image A that represents a fatty plaque here, and which is the darkness gray. The image B represents a fibrofatty plaque, which is a dark gray, more structural than a fatty plaque, but is still compliant. The image C represents a fibrous plaque, which is the lightest gray, more echogenic, normally more non-compliant, especially in concentric lesions. And the image D that represents a calcified plaque. So calcium is highly echogenic and appear on Ivus in bright on white, like here. And it's shown a acoustic shadow behind on it. So take a look just here. The third pillar of Ivus in PAD is the vessel sizing, and it is very important because vessel sizing is the way how to select the correct device. Lumen and vessel areas can be measured, and the percentage of area stenosis and the plaque burden can be calculated. So over and undersizing balloon and stent for PDA resulting in increased barotrauma and vessel injury or residual stenosis that we call recoil, and both conditions have been associated with a reduction of patency, obviously. So Ivus image measurement, the vessel dimension. In the image, you can see in gray arrow indicates the maximum and the blue arrow indicate the minimal vessel diameter here. And the average can be used too. So different than geography, the decisions become quantitative and no longer qualitative as angiography. So look the importance of Ivus to decide the vessel diameter, the balloon and stent size and length. You can change your way to treat using Ivus. And the last one, the fourth pillar of Ivus in PAD is the guide wire orientation. In many cases, a subintimal crossing of a CDO lesion with a re-entry into the true lumen may occur. This happens all the time, but using Ivus after a wire passage, the examiner will quickly recognize the wire orientation and be able to make a suitable device selection. For instance, using an atherectomy device in such a lesion may cause a subintimal media or adventitia injury, which may affect the patency and affect your result. On the other side, an intraluminal crossing of a CDO lesion has tremendous plaque burden and may need methodic plaque modifications before PDA or stenting, as an atherectomy. So the image represents an intraluminal position in A, while B and C represent the subintimal orientation of the guide wire. So look the difference. And Ivus also can be associated with a re-entry device. So look this video, the needle going out and it is guided by the Ivus. And to confirm of the four pillars of Ivus in post-interventional imaging of to treat segment is necessary. Ivus is superior to angiography alone in verifying the quality of intervention. Stent under expansion, malposition, or residual stenosis can be less frequently identified by angiography than an Ivus. Similarly, dissections and geometric miss can be better visualized by Ivus compared with angiography. So look how easy it is to identify the size of the vessel, the residual lumen, and the stenotic region using Ivus, also using chroma flow. Chroma flow is the color mode on Ivus. It's very easy to use, and it is available in Ivus 018 and 014. So to summarize all this information, here is the 4 pillars of Ivus in PAD. Number 1, vessel size. Number 2, plaque morphology. Number 3, plaque geometry, dissection, and CDO. Number 4, guide wire position, and final control. So we know that in analysis from the National Inpatient Sample Database, the use of Ivus was associated with non-significantly higher hospital cost, but a significantly lower rate of post-procedural complications. The stent kink resistance playing an underreported role in these positive clinical outcomes. Ivus has been shown to be superior to digital subtraction angiography in assigning vessel and stent characteristics, and the use of Ivus as an imaging tool to facilitate and improve the understanding of atherosclerotic burden and vessel dimension, thereby allowing for accurate device selection. So I want to invite all of you guys to follow Fogarty da Madrugada on Instagram and to listen the Frame to Vascular podcast, and it is available for free on Spotify and YouTube. I also want to thank you, Dr. Luis Leon, to improve my practical with Ivus in Tucson, Arizona, and thank you for Science Group for this opportunity on this presentation.